Hello, and I'd like to thank everyone for joining this meeting with the All-Party Parliamentary Group for Healthcare Infrastructure. I think it's an incredibly timely opportunity for this relatively newly restarted group to get going and engage in the, I think, pretty important conversations about the aspect of our healthcare and how it relates to infrastructure. Obviously, with COVID, the health system as a whole, the NHS, has been put under enormous amounts of pressure. Now, from that, obviously, we can see the challenges it's facing. We can look at the positive things that have come out of this experience, the understandings that have improved. But I think there's a great deal to learn, appreciate, and apply in the future. It's not just what we've been through in the pandemic as it's been, but also in the future, we've got an opportunity to remodel, redesign the infrastructure as it is. And we have the booster program, which we've got to carry on with. We've got the huge program of catching up with all sorts of work that the National Health Service is doing. So it's an immensely challenging time across the board. For this meeting, if anyone is going to be tweeting, and that'll be a very welcome thing as we go through the meeting and afterwards, if people use the hashtag HealthInfra, APPG, so if you use that hashtag HealthInfra, APPG, for any tweets or other messages going out, that'd be very positive for the group. Now, MPs, backbenchers, such as myself, we make sure that we visit our local health centres, our hospitals, our GP surgeries. So it's a pleasure for me to visit the team in Bolton 1 recently to see the work they're doing, listen to the challenges they have. And actually, it's a relatively new facility. And it's that opportunity to look at facilities around the country to see what works really well, whether it's during the pandemic or how we'd like to see things work in the future. The health service, obviously, with the health and care bill, is going to undergo a restriction to a certain degree. So there are obviously questions and significant concerns of how that's going to pan out in the future. I'm particularly interested in the integrated care systems and the boards that go with it, who sits on them, because I think there's a huge opportunity, a huge role in terms of the leadership that comes with that. But what I'm going to do now is I'm going to hand over to Professor Ted Baker, Chief Inspector of Hospitals and the Quality Care, the CQC. So I'd like to hand over to Ted Baker.
Okay, thank you, Chris, and thank you for inviting me to speak at this event. As you say, we're at a really fascinating time for the health service at the moment, learning from the COVID pandemic and building for the future. I've been asked to speak about the NHS Estate and the COVID-19 pandemic, but before I touch on that, first let me pay tribute to the way the NHS has managed what must be its greatest challenge in living memory. During the first wave of the pandemic, we saw enormous pressures on critical care, acute medical care, and respiratory wards. And more latterly, we've seen those pressures focusing on urgent emergency care, both within the emergency departments of hospitals, but also in other parts of the system, such as ambulance services. What I have no doubt about is that the resilience and commitment of the workforce has been critical to the way the services have managed these unprecedented challenges. Now, this applies to the frontline clinical workforce, of course, but just as much to the workforce that is behind the scenes, including everyone managing and adapting the NHS estate to meet the ever-changing demands of the pandemic. Wards were adapted to accommodate patients needing critical care. Infrastructure was changed and upgraded, for instance, making sure hospitals had sufficient supplies of oxygen during the first wave of the pandemic, when oxygen was the main life-saving treatment available. That was a formidable challenge, but it was met under the most demanding of circumstances. And I want to pay a special tribute to the people leading these services. They've made sure that day to day, under unremitting pressure, services have continued to deliver for patients. And they're still doing so today as hospitals continue to face the pressures of the pandemic on top of the normal recurrent pressures they see every winter. So there is much to celebrate and be thankful for as we come through this pandemic. but there is also much to learn. And it is important we learn the lessons of COVID, not just for the next pandemic, but so that our health services can be better prepared for any future challenges they face. I hope we can explore those lessons today, but let me start off with a few pointers to what I think we should consider. One of the things that has been important in our response to the pandemic has been the ability to convert clinical space from its usual use to different clinical use, often at very short notice. Inpatients to critical care, day surgery to inpatient wards, outpatient areas to emergency departments, educational areas to step-down facilities. The list of changes is endless. When we built our hospitals, we often plan for their use under normal circumstances, but do we build into them the flexibility so that clinical space can be transformed to meet the changing demands that may be brought about by short-term surges in activity or by long-term changes in clinical trends? There is an important lesson here. We should avoid building bespoke clinical facilities that assume models of care are permanent, and always build for flexible use as the needs of patients change. For instance, do we create space around emergency departments that can be used for expanded winter activity as a matter of course? Or do we plan for a certain fixed capacity of emergency department, regardless of the vagaries of demand? I would observe that in my experience, those emergency departments that can rapidly expand into adjacent space when they're faced with surges of activity, manage winter pressures, let alone pandemics, much better. Another important issue that the pandemic has brought to the fore is infection control. Many of our hospitals, if you go around them, are peppered with temporary partitions and screens to separate infectious and non-infectious patients because of COVID. Now, COVID is an important respiratory virus, but it's by no means the first respiratory virus we've had to contend with. And it seems that our hospital design has forgotten the lessons learned in the past about the spread of infection. Florence Nightingale knew the importance of high ceilings, space between beds, and plenty of fresh air. In our rush to move away from the undignified serried rows of beds in Nightingale wards, we seem to have forgotten the importance of physical barriers to the spread of infection. Now, does this mean, as some suggest, that we should plan to care for every patient in a single room in the future? I'm not sure I'm convinced about that, but we do need to review how the estate helps protect patients from acquiring infection in hospitals. Infection control is not just about COVID, but COVID has reminded us how important it is. This meeting was originally planned for, from what I recall, to commemorate the 60th anniversary of the 1962 hospital plan that brought us the District General Hospital. And the pandemic has stressed the model of care built on DGHs to the limit, and has demonstrated, I think beyond doubt, that the 21st century needs new models of care. Medicine has changed, the needs of the population have changed, and so has the way we provide care. That needs to change as well. A particular example I'd point to is the co-location of urgent emergency care and planned care in a hospital when they compete for the same clinical facilities. During the pandemic, this competition has led to a rapid increase in the waiting list for planned care. And last week, for instance, it was published, the latest figures were published, showed that the waiting list had reached 6 million. The Royal College of Surgeons has called for dedicated surgical hubs separate from acute hospitals. And in a report in 2020, my predecessor, Sir Mike Richards, called for the separation of diagnostic facilities for elective and acute care. Now, those are two really important proposals, and those proposals are the start of what needs to be a new hospital plan for the 21st century, reflecting the needs of today's population. And finally, I want to talk about well-being. Well-being of patients and well-being of the healthcare workforce. The clinical environment must not just be functional, it needs to lift the spirits of people providing care and those receiving it. It needs to be a healing environment. I only really understood this myself when I led the project to build a new children's hospital in London and saw the impact of the new building on children and families receiving care. I'm convinced that better environments do lead to better outcomes for patients. The COVID pandemic has taught us much, but perhaps most of all, it has taught us the importance of supporting the healthcare workforce. The environment needs to support them as well. The days of poor quality space for them to work in and poor quality space for them to rest in must be put behind us. The working environment must show how much their work is valued. So those are some of the lessons I think we can learn from COVID for the NHS estate going forward. I've only been able to touch on a few. I'm sure others will think about many others, and I look forward to hearing your views. Thank you very much. Back to you, Chris.
Thank you, Ted. I think an excellent introduction to this event. And just before we go on to Chris McCann, a reminder, at the end, we're going to have a Q&A session. So make sure you think of those questions. And just as Neil Hanvey's done, make sure you put your hand up as well so I can come to you in a timely way. Over to you, Chris.
Thanks very much for inviting me to address this group. So obviously, coming from Healthwatch, we're looking at this from a sort of a patient engagement side of things. And there's the obvious important things that need to be represented in terms of the physical infrastructure, having accessible buildings, etc., ramps, lifts, having the right signage in the right places, making sure waiting rooms are comported in the way they should be. But I'm going to talk about two specific aspects of infrastructure. And infrastructure can mean different things for patients and service users. So I'm going to touch on two that we've heard quite a bit about. On sort of physical infrastructure side, which is about supporting communities getting to and from appointments, I'm going to touch on non-emergency patient transport. And then I'm going to just talk a little on how making sure that improved access to digitally led healthcare is important, and making sure that is supported properly to make sure that communities are getting the access that they need. So in terms of patient transport, we did a fairly substantial report back in 2019, asking communities across the country how they wanted the NHS to improve locally. And we engaged with over 30,000 people across the length and breadth of England. And we found that travel was a really key issue. 9 out of every 10 people told us that convenient ways of getting to and from health services is either as important, they saw it as either important or very important. And in 2/3 of the country, communities told us they wanted more focus on local plans on improving the links between transport and healthcare services. So the report that we produced in late 2019 was called There and Back, and I can share a link to that in the chat later in the group if anybody's interested in it. But we put some action areas that are within direct NHS control, and some areas for action that will require the NHS to explore greater partnership working. Some recommendations I think that will feel very relevant to this group. So in terms of those recommendations, we recommended that the NHS needs to make a sector-wide commitment to involve transport commissioners and providers as standard in discussions when they are developing or reconfiguring existing services or developing new services. And this commitment should really cover changes to services at all levels, from any kind of major relocation of hospitals to the shifting of delivery of a particular service across, for instance, a new primary care network. Also, we recommended that local NHS services should work with their local authority partners to ensure that data health and the links with transport are fully considered as part of any joint strategic needs assessment. Local NHS leaders need to work with those responsible for car parking to improve the way systems work for people. This should improve putting in place policies to waive fines for people who get parking tickets due to NHS delays. NHS services should explore more ways of working in partnership with technology and transport companies to make more intelligent use of patient data. An example of this could be including services matching up records on address, patient preferences, in regard to transport data from local public transport timetables, and using this to support smart scheduling when offering appointment slots to patients. And it can also be used to keep patients better informed about on-the-day waiting times, so that people can make informed choices about when to arrive. It can also be used to tell patients when their transport will arrive, so they don't have to get it ready several hours in advance. So those are some of the recommendations that we've made on the transport front that really should be worked on with people who use services and patient organizations to ensure that the future shape of transport to and from appointments is people-centered. Then the second issue I'm going to talk about is in relation to the digital side of things. So We know that digital transformation has been a long-term strategic goal for the NHS even before the pandemic, and it was highlighted in the long-term plan in 2019 that every patient would have the right to digital first primary care by 23-24. But as we know, the pandemic has caused a rapid shift. We know from looking at the statistics, even in the space of 3 months, from January to March 2020, the proportion of appointments taking place via remote methods moved from 10% in January 2020 to just under 1 in 2, 48% by April of that year. So we talked to various groups of patients who felt challenges in using digital technology to understand the barriers that they face. We talked to people in older age category, 60 to 89. We talked to people who had physical mobility or sensory impairments. And we talked to people for whom English was a second language. So what we discovered is there are a number of core reasons why people find it difficult to use digital infrastructure to access care. One is some people just have a limited interest in technology. Second one is people sometimes have a lack of digital skills. Thirdly, there is issues of age and disability. Then there is issues of trust. Some people just don't trust using digital systems. Then there is language barriers, and then there's also the issue of affordability. And I suppose it's worth noting that if people fall into several of these vulnerable categories, there's an increasing likelihood that they become digitally excluded from access to care. But I suppose one of the things I'm always keen to point out when we talk about digital access is that there's been a bit of a narrative that you see sometimes promulgated in the press that digital bad, face-to-face good, but that's not always the case. Sometimes remote care removes barriers for some. So for instance, members of the public with mobility issues, or those with caring responsibilities, or people who live in quite remote locations actually find that the move to digital care has been really useful for them. So at Healthwatch, we have pulled together what we think are 5 principles for post-COVID digital care. So one is that it should be ensured that remote methods are maintained alongside traditional models of care to support patients and choose the most appropriate method of care to meet their needs. Some patients will want a face-to-face appointment. Some patients will want a digital appointment. And it's important that patients are able to access the type of appointment that they need. Secondly, there is a need to invest in support programs to give as many people as possible the skills to access remote care. And there's examples of many successful initiatives across the country, but ultimately these shouldn't be left up to local discretion. And I think the NHS could make a commitment to improving digital literacy, which is central to its post-pandemic recovery strategy. Then thirdly, there should be clarification about what patients' rights are regarding remote care, ensuring people with support or access needs are not disadvantaged when accessing care remotely. Fourthly, practice should be proactive about inclusion by recording people's support needs. So if particularly in primary care, if a practice understands that somebody has a particular need, i.e. you don't offer a phone appointment to somebody that has a sensory impairment that would prevent them from using that kind of service. And then finally, we believe there should be a commitment to digital inclusion by treating internet access for care services as a universal right. If we are seeing an increasing shift towards digital services, then internet for the purposes of accessing health and care should be considered as an essential utility in the same way that water or electricity is considered. And I know that the Lords Committee also made this recommendation. So that's just really some food for thought, I think, on 2 issues, on transport and on digital. So I'm happy to hand over to the next speaker.
Thank you very much, Chris. And I'd like to hand over to Dr. Minesh Patel.
Hello there. Thank you for inviting me to today's sort of meeting. I just sort of introduce myself. So I'm a GP, and I've been a GP for the last 25 years in Sussex, but I've also been involved for the last 15 years at various levels within the sort of commissioning structures of the NHS, including primary care trusts and latterly clinical commissioning group chair. So I've seen the sort of development of premises, both from the commissioning sort of perspective, but also from perspective of someone who might be a recipient, a provider of care. So I'm going to just tell my story, which might be typical of an average practice. I'm well aware that practices have had all sorts of different experiences of their sort of premises development. So over to the next slide, please. So I'm not going to go through this slide in detail, but the basics are that we're a pretty large practice, and we've grown very rapidly. And it's a typical building that I work in that's been extended many times. And we've certainly found it, I would typify our experience of working through premises development as being quite sort of frustrating and quite difficult to navigate, with systems often being developed as we're sort of going along. I would suggest that this is a fairly typical experience of a lot of practices. That said, I've been involved at commissioning level with some really fantastic developments, usually by third-party developing organizations who've really created some really interesting health spaces, health and well-being spaces, I would say. I would typify the sort of issues around developing health spaces as really primarily being around not so much access to capital, but often actually identifying recurrent revenues to support the capital development. And that I think is a really big challenge. And I think the other thing that I would sort of indicate is that every time the NHS has gone through reorganisations, often the new organisation will not necessarily carry on with the work that's already been done, and will often start to recreate new estates and premises strategies from scratch. And it can be quite difficult learning from the previous organisation, especially if people have moved on to new roles. So that can be quite a tricky scenario for providers to sort of navigate. I think latterly we've had some opportunities around workforce development as part of the primary care contract, the direct enhanced service, bringing new workforce in. And of course, the new workforce is very welcome, but obviously that introduces another challenge around how do we cite these wonderful people who are coming into practice. And it isn't just about giving them a room to consult in, but it's about offering training and supervision as well. So there are a number of challenges around the sort of expansion of workforce where expansion has been possible. If we look at new models of care, I'm just providing one example here, but group consultations, where we invite groups of people with similar needs to have a group consultation. That may feel like it's mass care, but actually it's a fantastic way of personalizing care and giving people the opportunity to interact with each other and to learn more. Well, you need large spaces for those sorts of events. And of course, over the last 2 years with the pandemic, a lot of this work, as Chris and others have said, has sort of shifted into the sort of digital space. But as we start to think about normalizing some of our care, we really do need to look at how we sort of create the right balance of remote care alongside being able to see people face to face for things like group consultations. So there are a number of challenges that we've faced, and there are a number of drivers that are going to really continue to challenge us. And I would suggest that with an aging demography and with the sort of obesogenic environment that we have sort of created for ourselves, we're creating a lot more in the way of need. If you look at what's happened with health inequalities over the last few years, unfortunately, the distribution of outcomes has widened, if anything. And we really haven't really adopted digital technologies quite as we could. I think My other organisation, the National Association of Primary Care, is heavily involved in bringing digital technology that already exists into health systems, and it's pretty evident that actually there are an awful lot of barriers within the NHS to bring technology that actually really does improve patient care and patient outcomes, and giving people more control over their care. So there are a number of challenges that we're sort of facing, a number of drivers. The one driver I think that we haven't really sort of mentioned at the moment, obviously, is the shape of the workforce. So as the number of GPs, or certainly full-time GP equivalents, drops, and the broadening of the team continues to develop, we're going to need to really look at how we start to provide the right sort of working space for the sort of workforce that's emerging, the right sort of training opportunities and the space for that as well. I think the final one really is around net zero. The NHS really does have to adopt a strong approach to net zero targets. I think at the moment it's not necessarily the biggest priority for the NHS, but it's certainly going to become like that very rapidly. And we have to look at the other dimension to that, which is green health. How do we start using environments differently to improve people's outcomes? Could we move to the next slide, please? So again, I would urge that we look at sort of our needs at the moment and the future in terms of population health. People often ask what population health means, and what that really means is looking at groups of people with similar health needs and thinking about how we're going to meet those needs. So finding the gaps in care, thinking about the workforce development, and looking at the distributed outcomes of those people, and really looking at things like the inequalities and how we're going to improve those. But if we think about outcomes, 85% of people's outcomes are not driven by health interventions. They're actually driven by wider determinants of health, so the social environment, the environment itself, and behavioral factors. So we really do need to think about how health spaces, health and well-being spaces really start to have a greater impact on improving those outcomes and reducing the distribution of outcomes within our populations. I'm part of a primary care network, and the whole agenda around integrated care is about bringing primary and secondary care, as well as social care and the health and well-being sector, and people themselves in communities much closer together to develop much better ways of delivering outcomes. Now, what we've already seen is quite a significant shift of care from the secondary sector during the pandemic into primary care, especially around people's follow-ups and where people have not been able to access secondary services. Bear in mind that 90% of all consultations in the NHS happen in primary and community settings, not in hospital settings. So the impact we can make through having the right infrastructure, and the impact we can make going forward around integrating functions of care, is going to be quite significant if we pay close attention to what we can do with health and well-being infrastructure in the community. I already work in a team of 55 people here at the practice. And if I was to look at our primary care network, we're looking at a workforce of about 180 people. So we are really working in truly sort of multidisciplinary ways, but that's still evolving, and we have to build the environment, I think, as Chris said, that is both fit for purpose in terms of improving the outcomes of people, but also supporting the well-being of staff themselves. Technology is going to be really important, and I heard a lot about digital exclusion earlier, and it's really critical that we build in the technology within our infrastructure to improve digital inclusion. It's only one part of improving inclusion, but it's really important. And I'm always astounded by the level or the lack of health literacy within a first world population. It's quite important that we actually start to level people up in terms of their literacy there's a direct link between health literacy and outcomes. So we must do that. Of course, we've got to prepare for future pandemics as well. So one of the things that we've learned certainly in the primary sector, as Ted Baker sort of was reflecting about the hospital sector, is that we've really had to think hard about our infection control measures and how we zone care when we need to, how we make sure that we're looking after people safely and not having someone who might be very vulnerable and have needs to come into the practice to be exposed to people who might have a highly infectious disease at the same time. Training, I think, is critical, and we've got to build the right spaces for that. If we don't have the right spaces, we can't do that. And whilst everything is digital at the moment, or a lot of things are, it isn't necessarily the most effective way to build teams. It's really important to be able to bring people together safely. To the next slide, please. So in my other role within the National Association of Primary Care, we've developed a tool with partners that really helps clinical commissioning groups and ICSs to take a much more systematic approach to build a model before building the premises. I'm all too used to money arriving within a system and then quickly being sort of dispersed and used to build infrastructure without really thinking about population need, without really designing in the care model, the workforce model, the technology model that could be used here and now, and then looking at how we sort of implement a premises plan, which might obviously is going to involve very much the existing infrastructure across the entire public sector, not just that which is in primary care. So we must take a much more holistic view to how we develop our model of care going forward. I'm going to stop there. Thank you.
Thank you for that, Minesh. Now we go straight on to Kate Edwards. But remember, if you want to get questions in the chat or put your hand up on the option that you got on your computer, please do that. But think of some questions, either get them on chat or put your hand up, and we go straight on to Kate Edwards.
Thank you, Chris. Today we wanted to give an overview of the LIF response to the pandemic, what that has meant for us as Community First and as LIF partners to the NHS, and what it has meant in terms of changes we've made to ensure facilities can meet the needs coming out of the pandemic. Next slide, please. In the early days of the pandemic, the public health guidance was changing and evolving, often on a daily basis. We saw the introduction of hot and cold COVID hubs, social distancing for patients and staff, the introduction of digital consultations. There was also an increased need for cleaning regimes, which often resulted in reduced capacity at these facilities. And this guidance, whilst absolutely necessary, has had a negative impact across the whole of the NHS and social care estate. We know that the NHS estate is widely variable. There are large numbers of older building stock that have got challenging configurations, often no natural ventilation and shared patient accommodation. So all this combined has made these required infection control measures challenging and in some facilities potentially unachievable. The advantage with the Community First LIFT estate is that it is inherently flexible design. These buildings were designed to be able to adapt to change in service demand over many, many years. Were we expecting to have to respond to a global pandemic? Well, probably not. But the design approach to these facilities has supported a very efficient approach to the requirements from the pandemic. Next slide, please. So what did the Community First response look like? Well, we set up a number of COVID-19 testing stations. We successfully implemented an infection control pathfinder project at the Integrated Care Centre in Oldham. This enabled us to provide pathogen-free environments in a high-risk area. We also created additional capacity with an interim assessment centre at Truro Health Park in Cornwall, and that's the picture that you see there on the slide. This enabled clinicians to support clinically vulnerable patients without them having to enter the main building. But we also changed our operational procedures. We wanted to be able to grant quick permissions for the extension of opening hours. We wanted to be able to uprate some of our FM tasks, such as flushing regimes. And we also wanted to make changes to our facilities management help desk protocol. And the reason we did this was to allow our teams to be able to identify and prioritise any COVID-19 requests. And also we wanted to ensure that we could support NHS colleagues as and when they needed it. So we enabled our rotors to have 2 property managers on call at any one time. Next slide, please. So as we've heard from other speakers today, the pandemic has taught us that for NHS infrastructure to continue to respond to these needs and the future needs of local communities, including different ways of working, we've got to have a whole systems response, whether we're designing new NHS estate or whether we're adapting older building stock by embracing new technology. We have to be willing to act on the lessons that we've learned. And I want to leave you today with an example of this whole systems response taken from the Integrated Care Centre in Oldham. The Integrated Care Centre is a 10-floor multi-tenanted building providing a wide range of primary care services. And we received a request from the CCG to create a hot COVID hub. This required a strip out of the area in the lower ground floor. We needed to redesign patient pathways, reroute IT systems, phones and security systems, and also to rehouse the displaced teams from this area. Now, we were able to achieve these adaptations all within a week of the request being made. And we were also working with the clinicians and the teams here to recognise the need to maintain maximum capacity in what is a high footfall, high infection risk area. And what we did was we introduced a new infection control technology called LumiBio. LumiBio is an advanced infection control system that enhances traditional cleaning methods. It operates in live environments, it's safe for building users and equipment, and it works to reduce infection risks for staff and for patients. But crucially, LumiBio is backed by regular environmental sampling, which actually provides evidence that the areas are pathogen-free, they're safe and clean. And this has really delivered outstanding results for over 18 months now. For us, this is a great example of this whole systems response to the pandemic and how we can be thinking ahead to how health infrastructure can continue to meet these changes in service demand. We need to ensure that we've got fit for purpose facilities that are supported by robust systems and to be able to embrace new technology. And in doing this, we will be supporting local teams to then support local communities and to also enable capacity to be resumed back to pre-pandemic levels. Achieving this requires long-term successful partnerships and partnerships that work together, sharing of best practice and embedding continuous service improvement strategies. And importantly, we need to rebuild public confidence that all of the health and social care infrastructure can deliver services fit for the future and local communities, and also that it will be a safe place to be. Thank you, Chris.
Sorry, I lost the screen for a moment, so I couldn't put it back onto audio. Thanks for that, Kate. Thanks to all the speakers who have given us a really good overview, really good insight to many of the key factors we ought to be considering at the moment. So I think first question, I'll go to Neil Hanvey and then Pete Donnelly. Neil Hanvey, can't hear you. I don't know if you're on mute still.
Problems with my controls. Thanks, Chris. So my question really is, thanks to everyone who presented. It was all very interesting and helpful stuff. My question's more around intangible infrastructure, and so the things feed into really functioning, and so around 2 in the pandemic.
Neil, sorry, sorry, can I just ask you to hold on for 1 minute? That was breaking up a little bit. If you could ask that question again, that would help. Sorry.
Okay, I apologize.
I think you may have lost him.
Yes, sorry. Neil, I don't know if you can hear me, but I think we've lost you at the moment. So I'll go on to Pete Donnelly.
I think I'm back now.
Okay,
we can hear you, Neil. Yeah,
give you another go.
Sorry about that. I don't know. I've had some problems with some of my Wi-Fi. Yeah, so my question is really about sort of intangible infrastructure. So things that feed into a good functioning health economy. And 2 things that struck me during the pandemic were, one, the impact of shortfall of fundraising for the charitable sector, and particularly life sciences, and its impact on research and development generally, and the consequential impact on the delivery of healthcare and research downstream from the pandemic. And the second one is again around the same kind of issues, which is the diagnostic sector in particular. I know it's a particular hobby horse of mine, but the domestic diagnostic sector, and making sure that we continue to invest and drive that and other associated sectors forward, because the quality feed through education, investment in R&D, and the latest the access to the latest technology is really central to a good functioning health economy. So I'd be interested in views on those intangible assets. I think education was touched on a couple of times, but so thanks again.
Thank you. So there's a number of points in there. So I don't know if Ted, would you like to start? And then if other panelists would like to respond to the parts of the question that they would.
Yes, thanks, Neil. It's a great question, actually. One of the things I think we can learn from the COVID pandemic that perhaps hasn't been talked about enough was the importance of the NHS's ability to drive forward R&D very rapidly. And I think one of the great successes of the pandemic, we've talked a lot about vaccines, but there's an awful lot of learning about how better to treat this new disease really effectively. And the NHS has excelled in taking that forward. And I think it has pointed to the real benefits of research and development in driving real change and real benefits for patients on the ground. And that's that link between science, research, and improve outcomes for patients has never been clearer than during the COVID pandemic. And I do hope that as we learn from this, we learn to focus our research and development on those things that are going to make a real difference to patients, large numbers of patients. And I think probably just reflecting back before COVID, there was a kind of sense of research was being driven by, if you like, the scientific interest rather than the needs of patients. You know, and everyone's fascinated by the science, but actually the NHS should be driving that research. It makes a real difference to patients. And COVID has demonstrated the importance of that. And I think it's demonstrated the importance of research into infectious diseases as well, which again, probably was not to the fore going forward. In terms of diagnostics, absolutely. I think we do need to invest in diagnostics. I mentioned the Mike Richards report from 2020 about diagnostic hubs. We need the diagnostics to be where people need it, rather than people having to go to the diagnostics. I mean, Chris was talking about the problems of transport and patients getting to hospitals. But why do we make patients go to hospitals as an outpatient to get an X-ray or a CT scan or an MR scan, an ultrasound scan, or a blood test, when, you know, we should be providing that locally? And this is one of the things that we need to change in terms of models of care. We need to bring the care to the patients rather than making the patients drive or take the bus or whatever to the care. And I think, you know, if you talk to patients when we inspect hospitals, patients will raise lots of concerns, but one concern they always raise is transport and car parking. Absolutely, that is a constant problem for patients trying to get to hospitals and getting the care they need.
Thanks, Ted. I think, Chris, it'd be ideal now if you want to add a comment or two. You're on mute.
I suppose to me it comes back to the point that Ted made at the start. It's about making sure that whatever development is taking place is being driven not just by the science side of it, but by engaging with people and speaking to people on any potential changes and developments in service, so that patient voice is being heard and being heard at a very early level in terms of informing plans as they're being put together, not as an add-on at the end as a tick boxing exercise. And I think we'll find that if we continue to engage with the population and with patients at the earliest possible juncture, that will achieve better outcomes in terms of the services and the infrastructure that we create, and better outcomes for patients.
Thanks. I don't know, Minesh and Kate, if you want to comment on this.
Yeah, I'd be happy to. I mean, I think there are the hidden parts of the infrastructure, aren't there, that have really struggled through the pandemic. I would cite hospices as being one, but if you just look at all those wonderful voluntary sector organisations that have been funded, at a marginal level, for quite a long time, all of these organisations have really struggled. Well, I'm generalising a little, but they've struggled. In particular, hospices through the last 2 years with the inability to fundraise in the way that they had been before, and it really does sort of open the wound, I think, around the entire sort of funding model of hospices and what they're there for and how integrated they are within the system. I think that there's a long way to go in ensuring that we provide a really high quality service for people in the last 1,000 days of their lives, really. And especially right at the very end. In terms of education and training, yes, agreed. The environments I don't think really support, a culture of training in the way that you'd expect to have not worked in a hospital for 35 years as it goes. But I know when I've gone into hospitals, my local hospitals, to look at training facilities, it's all a bit of a mishmash. And it could be better, and and there isn't really an obvious approach to developing training facilities in communities, really. So I think we need to really look at that. I've been to places like Gesundes Kinzigtal in Germany, where the primary care facility has actually got sort of open spaces, both for the community to improve their health literacy, but also to deliver sessions with patients, and it's a wonderful thing. Co-located with a gym as well. So we've got to really think quite laterally about what these spaces are there for and the art of the possible. Really.
Minesh, one of the things when I've spoken to people who run hospices is they always have great concerns over the funding, and especially because so much of it's by donations, and only a fraction of a significant proportion, but only a relatively small proportion is from the state. But one of the things they quite like is the independence and the flexibility it gives them. One of the things we need to be thinking about now is that kind of the ability of decision makers perhaps closest to the service users that they need. So do you think that's one of those challenges of whether it's through the NHS or other mechanisms that actually, to some extent, the flexibility that hospices and other organisations have now, that how we can get that sense and that flexibility into the wider system?
So I think you're absolutely right. So hospices very definitely, and I've had local experience of this, really want to remain quite independent. And there's a branding issue, I think, if they become far too sort of subsumed within the service itself. That sort of fundamentally impacts on how you can sort of fundraise, amongst other things. But equally, I think that the current model, which usually involves the kind of annualized cycle of funding, which the NHS is prepared to make into the hospice sector, which is largely based on how the NHS itself is funded, really, doesn't really help. And I think forward visibility, anyone that runs a business knows that you have to have forward visibility of your investment in order to build your workforce build it well, and to continue to develop your service. So I think it's just about tweaking the model. Does it work for other sectors? Yes, I think it does. I think it's entirely translatable for other third sector organizations. So we really need to look at not treating different organizations too differently within the ecosystem, but making sure that we look after all of them as best we can.
Thank you. And Kate.
Thanks, Chris. I just wanted to go back to the point around how we plan services and where they are based. For us, we're seeing some really good examples, particularly in our area in the south, where we're starting to provide diagnostic services, not necessarily new builds. It's adapting existing facilities to be able to meet the demand for diagnostic services. One of the things that I don't think we've picked up on is the challenge around the workforce and recruitment to staff these additional facilities. Because right now, where we're still firefighting with the pandemic, we're putting in additional services and an additional site that will reach rural populations and avoid them having to go to A&E or somewhere else. But the biggest challenge for the trust that we are working with is around recruitment and retention of staff to support these facilities. So I think that is happening. We are taking that on board in terms of strategic planning for population health and communities that are in rural areas. But we have to make sure that we follow through with those other systems to be able to make sure that they are successful.
Thank you, Kate. And I realise we're running out of time, but Pete Donnelly.
Thanks very much. I'd just like to ask a question following on from Dr. Patel's presentation. Just to give you a bit of background, I work for a community interest company, the Wheelchair Skills College. And our vision is to ensure that every wheelchair user across the UK, or 1.2 million people, have the skills and the independence to use their wheelchair effectively. I've been using a wheelchair for 15 years now. I've been teaching wheelchair skills for 13 years. It's something of passion of mine, and I realised when I look back that the only reason I've been able to do all the things that I have done, whether it's travel, whether it's work, is because I've got the skills and the confidence to do this. What we do in the Wheelchair Skills College is teach people of every age and every ability the skills they need to get around. And that we've been running skills with local wheelchair skills service so far, but the idea is to get integrated into every point of a wheelchair user's life. So I'm working with schools and colleges, working with DPOs, really keen on working with various departments at NHS as well. And I think that I was just wondering, from what you were talking, Dr. Patel, around the group consultations for wheelchair skills themselves, but also in the wider remit of bringing that lived experience in, because there's so much lived experience outside of clinical needs. Is that possible to bring that into the group consultation environment? Because that element of peer support as well is so important for patients.
I thank you, and I think that raises a really, really important point. I think you're entirely right that the group approach really does apply in so many different dimensions. It isn't just about people with long-term conditions. It's also about people who can connect with each other around similar needs. So my points around population health and improving population health is to look at people with similar needs and to address those needs in the most sort of practical and helpful way possible. So yeah, group consultations around the sort of needs that you're describing would be excellent. I've seen group consultations being developed around people with mental health problems, with people who have hearing disabilities, people who have visual impairments, antenatal children, all sorts of different applications. And I think it would be a great thing to see one developing around the sort of area that you're talking about. Fabulous.
Thank you. Does anyone want to comment on that? Or I've got a question from Joe Siddles. Chris?
I suppose just a comment from me, just in terms of that consultation point, it just reinforces the importance to me of making sure that patient voice is heard, particularly as we move into the new ICS level. So when the ICBs and integrated care partnerships are being set up, that those local systems are giving due cognizance to the voice of the public when they're making any decisions on service development or delivery.
Yeah, I think that point, Chris, is brilliant. So the health and care bill going through Parliament at the moment, the integrated care system, the partnerships and the boards, don't know how it's going to work out, but having the right range of voices on the boards, obviously from the health service itself, and from patient groups, and I think wider elements interested in the sector, the health sector. It's going to be interesting to see how these develop and what kind of difference you get in different areas, different parts of the country, the different focuses, and the opportunity for more leadership to come through in the health system. So I think this is going to be a very interesting area in the coming months and years. So I think we may have a few minutes for a little bit of an overrun. I appreciate some people may want to dip out at that stage, but I'll ask Joe Siddle's question. So if I'll go through each of the panel, and if the panelist also wants to add any closing comments to anything that's been raised so far, but also in response to Joe's question. So her question is, the pandemic has given healthcare providers the opportunity to assess how they deliver their services, where the solution is to deliver care face-to-face rather than digitally services. How can now find themselves competing for space? How should competing services be evaluated to prioritize which should be successful in securing space, especially when services are delivered by different NHS organisations? And sometimes I suppose it won't just be NHS organisations, it might be other organisations that are brought in to provide a service. So I'll stick to the original order. So if I go to you first, Ted.
Thank you very much. I have to say we've touched on this, but we haven't, and you've touched on it, Chair. The development of integrated care systems, and I think that to some extent provides some answers to Joe's position, but also to some of the other questions there and some of the other discussions we've had. I think there is a real opportunity going forward for integrated care systems to focus on the care for the population they serve and build that around the priorities for that population, addressing the health inequalities in that population as a specific, and not, if you like, one size fits all from the centre. NHS is a very centrally driven organisation, and I think we now have an opportunity to make it much more locally driven, where it's influenced by the needs of the population that the services serve. And that's going to mean the ICS bringing together all the different services and trying to make sure the models of care for their area fit the needs of their population and their geography. The model of care for the middle of a big city should not be the same model of care for a very rural area. Inevitably, they're going to be different. You provide care in different ways, and you'll have a different population in both areas as well. And you need to build that care around the needs of that population. So I think ICSs are a great opportunity. The NHS is great at having reorganisations, and reorganisations sometimes change the structures, but don't actually change the services. We must make sure that this reorganisation changes the services people receive. So people are getting a service that's based upon their needs, the population needs. So that's the great opportunity coming forward in this year. Okay, thanks.
Thanks, Ted. Over to you, Chris.
I suppose I'm really going to sort of just reinforce what Ted has just said, is people want choice over the kind of appointment or consultation that they have. So, and that's what has come back to us in all of the sort of the qualitative work that we've done with various patient groups. If you take a look at the pandemic, we've frequently heard people say they understood the need for the shift to remote methods during the pandemic and felt they had been good enough given the circumstances, but they were concerned that might become the only option, and they felt that they might lose something in the long term if they couldn't have the option of returning to face-to-face. So it's about making sure that the patient is able to access care in the way that's right for them at the time that's right for them. I suppose this was pulled out, I think, in that when we spoke to people about their specific experience of a remote consultation, they were more often than not, they were actually satisfied with the quality of care. But when it was spoken about in a sort of more general terms about a broader shift to remote care, people were seemed more unsatisfied. So it's about making sure people are able to access the the right type of consultation for them at the time that suits them.
Thank you, Chris. Minesh?
Well, I will say double ditto, but you know, in addition to that, you know, I guess we need to be much more flexible in our thinking. I think that's what the pandemic has taught us. But thinking about Ted's point about integrated care systems, they're either a golden opportunity or an own goal. And it depends on your system leaders. It depends on your system engagement, in particular with communities themselves. And in particular, I think with the concept of value-based care. So what brings the best and maximum value to an individual and a community? And if we don't embrace that concept quite significantly, we're going to come a cropper. We don't live in generous times. We don't have a surplus of money, and we don't have a surplus of workforce within our sort of economy and our system. So we do have to think quite carefully about what really brings value to people. And it could be as simple as, I cite one example, just a recent one, putting a bench in Sainsbury's so that your, an older people might be able to actually go out and go to Sainsbury's with their family, but they've got somewhere to sit. That could be just as important as offering someone else a shoulder operation, which may actually have very little in the way of outcome, evidence. So I think we really do need to look at value quite differently, and that's where ICSs should be really thinking.
Thank you. That's a really interesting example of it. It is often the smaller things in life that really count the most. But over to Kate.
Thanks, Chris. As ever, I agree with everything that the other speakers have said, but I just wanted to add an additional point here. And it's something that we touched on the slides earlier on about this key to having flexible space. So in terms of Joe's question, where Joe is saying that there will be competitions for space and who gets priority, we not only need to offer choice for patients, but we need to offer choice for clinicians, where they work, how they work, and what type of space they're going to be working in. And we need to have a design approach to the facilities that we develop going forward that allows other clinicians and allied health professionals to come into one building one day and move into another building another day, to be able to provide that full range of flexible care.
Thank you, Kate. Well, that brings us to the end of this session. I think it touched on and went into reasonable detail in such a range of vitally important topics, pertinent to where we are at the moment, and especially important to where we're going and developing the infrastructure in the months and years ahead. So I'd like to thank Professor Ted Baker, Chris McCann, Dr. Minesh Patel, and Kate Edwards for your excellent contributions. I'd like to thank all the work from the team in the APPG for health infrastructure. So much work goes on into making these events successful. I appreciate, and I apologize for not being able to get all of the points and comments in from the sidebar or the chat, but I think one or two of the points, if Mike, you can chase up afterwards with the contributors. So thank you to everyone. And the next meeting is on Tuesday, the 8th of March. So the details will be announced for that shortly. But if you do want any further details, do please look at the website or the Twitter. But thank you all very much.